All right, so for July, we're going to discuss documentation of a patient encounter. I know this is a subject that's near and dear to all of us, and I think some of you are probably thinking, well, I do this every third day. Why do we need to have a talk on it? Well, I think it's important that we talk about what constitutes a patient encounter, what constitutes documentation of the patient encounter, and how we can do it better. I know we're all looking at what we do and how much time and effort we spend in documenting, but really documentation is an important part of our process. So what are we going to talk about today? We're going to talk a little bit about what is a run report. We're going to talk about why do we write a run report. I'm going to give you some tips on how to write a report, as well as pitfalls and some pearls of wisdom that may be helpful in the future. So what is a run report? Well, it's a clinical record of care. It's what we use to document the care that we provided to a patient. And that's what we think about on a day-to-day basis. We're recording what we do for this patient. The record, though, also is a legal document. It can be your best friend or your worst enemy if you're challenged regarding care you provided, but it's also a legal document for people who may need documentation of their illness or injury as part of legal proceedings against someone else or some other entity, such as a business. So it is a legal document in that record. It's also an operational document in that it records data. And we now file data with the state as part of MCERS. We now, for most of our departments, have transitioned to electronic patient care reports such as ImageTrend and ESO, where we can run audits on data elements that are contained in the record. So we can get operational information out of this. For instance, an example would be how long does a unit stay on scene, or what is our average scene time for patients with an ST elevation MI. So we can take that data and run reports that we can use to improve our operational performance. It's also a financial record. So all of our agencies, to my knowledge, bill for our services, and you can't bill for something that you can't document. So it's a financial record. It documents the care that we provide, and it justifies the fees that the billing office may submit to the patient or the third-party payer. And finally, it's a compliance document that we use to verify that we comply with laws and rules. An easy example would be we have a patient who's a victim of trauma. Their injury meets the state trauma triage transfer requirements, and we document in the record that we transport the patient to a trauma facility. Therefore, it's helping to verify that we're complying with the state rules. Why do we write a report? Well, we write a report because it documents our patient assessment. It documents our actions, so those interventions and procedures that we perform on the patient. It does, to a large extent, document our thought process. So why did we do what we did? So we have to have some record that substantiates that. It also serves as a means of communication, and that really is in line with continuity of care. More and more, medical care is being seen as a continuous event from the time of first medical contact to the point of patient discharge. So what we do in the field is often the first steps in that episode of care. So our documents will communicate to the receiving facilities, receiving physicians, what we have done. I now regularly see our hospital-based internists or hospitalists asking for the EMS run reports because they want to obtain information regarding the patient's care prior to arrival at the hospital. And our records serve as a form of continuity of care. Yes, we kind of start and stop. We start with the patient encounter. Our encounter ends when we hand off the patient. But really, as that concept of continuing care, our record helps substantiate and document what we do in that regard. So I mentioned before, the patient care report is your best friend or your worst enemy. So it just depends on what you have documented. And I've kind of spent a couple slides going over documentation 101. A lot of this may seem redundant if you're an experienced provider, but I think if you listen hard, I think you'll get some tips of the trade as we go. So why do we document, and what are the basics of documentation? Well, really the basics are that we document what we observe, we document what we did about what we observed, and then what happened after we provided some care or performed some action. So that's really the three basic components of what we document. What did we see, what did we do, and what happened after that. And it's important that when you do this, you also look at reading your report before you submit it. So you need to proof it, look for spelling errors, look for inconsistencies when they're within the record. And it's inconsistencies that will often come back to bite you in the backside. So a report is well written. A thorough patient care report suggests a thorough, efficient assessment and quality of care. A sloppy record suggests that your care was sloppy and that you didn't provide appropriate, efficient care for the patient. And as I remind people frequently, spelling does count. So if you have the ability to check your spelling, please do, because if your words are misspelled, if your punctuation is terrible, if you use all caps as part of your narrative, people are going to look at it and think, well, does this guy really know what they're doing? So spelling does count. An effective report is completed objectively. We document our observations rather than assumptions or conclusions. So we should not be making assumptions, but we should be documenting directly what we observe. And we should document behavior rather than concluding what type of behavior it was. And I'll talk a little bit about that more later. We should avoid the use of emotionality and value-loaded words or phrases. We should document our physical findings and direct observations, and what we document in our report should be legally relevant and in compliance with established standards of care, because that's how we're going to be judged, particularly if somebody has reason to look at the report or there's concerns about the care that you provided. You should keep in mind that every patient you care for has the right to review their medical record and can contest anything you have documented. So if you document things that are readily observable and that are easily verifiable as facts, that is easy to substantiate and support and defend versus conclusions and comments or editorial opinions that patients or their family members may find offensive. Elements of a good report includes a clear picture of what happened, including relevant facts as well as pertinent negatives. So often pertinent negatives are as important, if not even more important, than some of the pertinent positives. So, depending on your clinical scenario, you need to think about what is important from a negative perspective as well as positive. So if a patient has a head injury, it's not just they had a head injury, but they did not lose consciousness, or they are not on anticoagulants. So I'm kind of using those as examples of pertinent negatives. It should be accurate with specific details related to the call. You really should put your findings down as objectively as you can. Now, it doesn't mean that you can't document others' observations as part of your narrative. For instance, if you're called and the patient is unresponsive, but family members are there, you can document their observations, such as when was the patient last normal, how they've been acting in the past couple days, and so on. And again, your report should include facts, not assumptions or conclusions. And it needs to be complete, and are all the boxes checked? And I think that when you think about that, it doesn't mean that every patient has to have a report that's got every body part assessed, but are all the pertinent boxes checked? So if the patient has had an altered level of consciousness, have you done an appropriate neurological assessment? Have you performed a finger stick blood sugar? Have you obtained vital signs, and so on? So you have to get things documented that are pertinent to the patient's presenting complaint. And then your reports have to be timely. It really concerns me when I see that run reports are not completed by the end of a shift. Do you really remember what happened with this patient when you work your next shift 3 days later, particularly if you've had a day where you've had 10 or 15 runs that day? I know for me in the emergency department, I can have 2 or 3 elderly patients in a row, and they all kind of become a blur. So I will document as soon as I can, so I don't mistake one patient's symptoms for somebody else's. Report writing, it should give you really a step-by-step account of the care you provided. Preferably, it should be in a time sequence, particularly for procedures. It should reflect your professionalism, and a lot of that has to do with how you document and how well you write as part of the narrative. Document exactly what you did and when you did it, and the effects of your intervention. So if you find a patient to be hypoglycemic and you give them 100 milliliters of D10, do they wake up or not, or do you have to give them another dose? You need to avoid using non-standard abbreviations or jargon that's not commonly understood. So if you have some of your own personal abbreviations, you probably should not be using them. We don't have it, but there are EMS systems that actually have a listing of accepted abbreviations. I know hospitals have a list of accepted abbreviations. So if you're going to use abbreviations, make sure they're abbreviations that are recognized by all other healthcare providers. And then finally, if you don't know how to write it in medical terms, write it in English. So if you listen to somebody's chest and you hear crackles and you've forgotten that the word Ralls means crackles, you can, instead of saying auscultation shows Ralls in both lung bases, you can say there are crackles in both lung bases. So use words that are descriptive if you don't remember or know the medical terms. You know, another thing is if the rash is splotchy and red, then say it's splotchy and red. Don't worry about coming up with, is it petechial or is it ecchymotic or is it purpuric? Just describe what it looks like. Some other basics of documentation: needs to be legible. Legibility in the past was an issue when we had to use paper reports. Now that things are electronic, legibility is generally not an issue. Look for spelling errors, and make sure that the spelling is correct in terms of context. So some words can have multiple meanings with different spellings, but they sound the same, like morning and morning. Are you mourning for the dearly departed, or is it in the morning and the sun has come up? Again, use approved abbreviations. Keep it short and sweet, but the appropriate facts are present. I have some runs that I've seen where there's 4 or 5 lines, but everything is there that I need to know about that run. And I've seen other run reports where there are 2 or 3 paragraphs, and I still don't have a clue what happened. So, short, succinct, with appropriate details. Keep out the editorial issues. Particularly, don't put comments in your run reports that reflect poorly on the patient's home situation, the facility where they're located, your fire department, your coworkers, or the receiving facility. So keep those editorials out. If you have concerns, such as the circumstances of the patient's home or how you were received at the hospital, follow up with your supervisors and we'll deal with it after the fact, but don't put it in the record. Your times need to be accurate, particularly if you're talking about scene times and timing of interventions. We need to know when the 12 lead was done. Now, fortunately, most 12 leads are time stamped by the device, but if you do interventions, the best we can do to get accurate times. Other things that have to be accurate are such as times of last normal, particularly with stroke patients. So, when was the patient normal? And that can often be a bit of detective work to actually find out when they were last normal. We need to include vital signs. Every record should have vital signs unless there's absolutely no way you can get them. And vital signs are kind of, if you do one, you need 2. It's always good to have a set of vital signs just prior to arrive at the hospital. We also need to document those treatments and interventions and medications that are provided. And our actions need to be consistent with the protocol. So if there is a problem with the patient where you have to deviate from the protocol, then there needs to be some indication in the run report that there was a deviation and justification for that deviation. And then the last thing, which is a common tripping point for all of us, is the narrative has to match or be consistent with the remainder of the documentation. So that if you're sent out on a patient who's short of breath and your exam is normal, then why is there an intervention where you're providing a breathing treatment, and how does your narrative support what you did? And I've seen that where it looks like the patient's just fine, but the narrative indicates the patient was short of breath, they needed supplemental oxygen and a breathing treatment, whereas their exam indicated they were normal. So look for those inconsistencies. That's what can hurt you. Special documentation considerations, and a lot of it has to do with refusals. Refusals are high risk for us, and I think we can argue that they're often overused. And we have to document, as part of refusal, the patient's state of mind. Do they have the capacity to make an informed decision at the time of their refusal? We need to make sure there's documentation of why we think there's care necessary, and we need to document that we have informed the patient of the risks of refusal and document our attempts to educate the patient. We currently have a refusal list in our protocol, or a refusal checklist in our protocol. I would suggest you use that. It's my interest that we work toward having it embedded in our electronic patient care reports within the next 6 months, so that every patient refusal gets a checklist as part of our documentation. That's to protect you, it's to protect the patient, it's to protect your EMS system. So think about those high-risk situations. We could go over a couple documentation tips. Some of them may seem to be redundant. One is, again, using correct grammar and spelling that does reflect on the professionalism of you and your department. I like to avoid words such as appears or seems. So rather than say the patient appears to be uncomfortable, we could say the patient's unable to find a position of comfort and is writhing in pain. Or we could avoid saying the patient doesn't seem very sick. We can say, however, that the patient is alert, eating chips and texting on their telephone. I think that conveys an appropriate idea to others in terms of how acutely ill this patient was on the time of your arrival. We ought to document changes and responses to changes so that if we change the treatment plan or we provide an intervention, how does the patient respond? And we should reassess the patient periodically, and I think it's a good idea to indicate that the patient's been reassessed and what is their status on reassessment. Ideally, that's time-stamped, but if you indicate in your narrative that the patient was assessed and appeared uncomfortable or was uncomfortable, patient was treated with fentanyl for pain, patient reassessed 10 minutes later, and now their pain is gone and they are resting comfortably on the cart, I think that's good documentation that supports our actions. So, if you do something for a patient, we should make an effort to document a second assessment and document the response to our intervention or treatment. Vital signs and intervention, we need to be aware of vital signs. It really is an important indicator of how we're doing, and it really does helps support any thoughts of how acutely ill or injured the patient is. So I think we should work toward having at least 2 sets of vital signs on the records. If the patient is really sick, patient's deteriorating, every 5 minutes would be appropriate. If the patient is stable, then I would suggest that we do vital signs either every 15 minutes or at the time of first contact and just before delivery to the hospital. It's always nice to have 2 sets of vitals on the chart, and it's probably at least once a month we have a case where somebody acutely deteriorates between the ambulance bay and the bed they're assigned in the emergency department. It's nice to have vital signs at the time of arrival at the hospital support that we didn't miss something, that the patient truly did deteriorate during patient handoff. We need to document medications given. That includes the time, the drug, how we gave it, and how much of the drug was given. For IV fluids, we need to indicate the size of the bag and the catheter used and where we placed it. And I think that's pretty straightforward since we carry 1 liter normal saline. We also need to document times on all critical interventions because those times are important. How can we improve? Well, clear document what you found when you arrived. Document an appropriate patient assessment, and again, include those pertinent negatives. Make sure the treatment is consistent with your impression. So if your impression is acute bronchospasm, then our treatments should be in line with that. Or if your interventions are you placed a splint, but your impression is COPD, there's a disconnect there. And we really need to have adequate documentation to verify that you followed the protocol. So if there's any question asked, we can justify your actions. I do want to spend a little bit of time talking about the narrative. There's a bit of an art to it, and it's something that comes with time. So, why do we do a narrative? Well, the narrative is a way of communicating your thought process. It explains in many ways what you did and how you did it and when you did it. It justifies your actions, and it fills in the blanks. there's a lot of records that we have. If you look at them, you really need the narrative to understand what happened with the patient and why things were done the way they were done. And the narrative has to match the exam and the procedures that are documented elsewhere in the report. And that's one of the biggest deficiencies I see when I look at run reports is that disconnect between the narrative and the remainder of the documentation in the record. Now, there are two different formats you can consider using as part of the narrative. I was born and raised on SOAP, which is Subjective, Objective, Assessment, and Plan. And I use that now as part of my notes, and I even use that as how I formulate my notes, even though I may not call out S, O, A, and P. So I'll start with the description of the patient history, a note on what I find, a note then I'll include my assessment. What do I think is going on with the patient, and what my plan is for therapy. And I particularly do that when I'm doing follow-up notes on patients in the emergency department. I've seen others use chart, which is, I know, commonly taught in medic school. Chief complaint, history, assessment, treatment or RX, and transport. I would suggest you think about using one of these as part of your narrative. Again, I'm less concerned about whether or not you use the acronyms themselves, but use that as a way of formulating your thoughts so that things flow well. I think if you follow SOAP or chart, people will review your narrative in a much more positive way. So what do we want to include in a narrative? We need to document delays in response. So if there is a delay in getting to the scene because of weather or train or traffic, put that in there. I think we need to make sure as part of the narrative we document elements for time-critical events, particularly if they're not documented somewhere else in the record. So really for time-critical events for trauma, we need to have GCS documented. That's can be done as a section of the record. We need to discuss the mechanism of injury, which I would see as being part of the vital sign or part of the narrative. We need to have some discussion of vital signs, particularly if abnormal vital signs result in intervention. So it could be patient has tachycardia and tachypnea, no breath sounds in the left lung fields, left chest decompressed with an 18 or 14 gauge needle. And then we also need to discuss the interventions that we perform. And one of the things I think particularly need to talk about with trauma is your decision to not immobilize the cervical spine in a patient who has significant mechanism of injury. So, if the patient has no distracting injuries, no spinal tenderness, they're fully awake, they're not under the influence, you can avoid immobilizing the spine with a collar. But if you make that decision, you need to explain that as part of your narrative. I think for the STEMI patients, they are time critical. We need to include our interpretation of the 12-lead electrocardiogram, what was in it that prompted us to treat them as a STEMI. We also should indicate that we transmitted the 12-lead. And then document the time of aspirin administration. For cardiac arrest, there are some things that I think we have to document in the narrative, such as the initial rhythm, whether or not there was bystander CPR or AED use. I know for APCRs there may be a checkbox for that, but if you can't find it, it has to be in the narrative. And then whether or not the arrest was witnessed or unwitnessed. Sepsis is, for me, the fifth time critical event out there, and it's also the hardest for us to identify. But we have to have some reflection on the vital signs, the end-tidal CO2, whether or not we gave a fluid bolus, and discuss whether or not we have a potential source of infection. So if the patient has a decubitus wound, has evidence of cellulitis or pneumonia, has an indwelling Foley catheter, those are all potential sources of infection, and we should make mention of that as part of our narrative. And again, as part of the narrative, we should think about limiting the use of abbreviations. And if we do use abbreviations, use those that are commonly recognized by medical providers. So what I like to do now is I just got two quick narratives I'd like to show you, and I like to contrast the difference. Both have to do with STEMI patients. So this is the first one. This is a direct extraction from a record. My apologies. The quality of these images is not the best. But this is a patient with a STEMI, and I look at it and it really doesn't tell me much. There's very little documentation, and I'm basically showing what's listed as part of the assessment and what's the narrative for the patient. Now you look at that, and You contrast it to this one where I have a much better idea of what's going on with the patient. The patient's 77, has chest pain. There's a description of the pain. There's a history of past illness. There's a good assessment of the patient, and then there's a description of the interventions were performed. This provider used the chart method, and you can see that things are formatted and formulated in a way that it flows and makes sense. So this is my example of a good narrative. It gives me the information I need to know in order to evaluate the patient and evaluate the care provided by the EMS providers. So, think about that. Some documentation pitfalls. Be aware of the ability to check all normal or not examined check boxes. If you check all normal, well, did you really do everything that's down as that all normal? Or if you check the non-examined, did you somehow miss those things that you should have examined? So if the patient's got a complaint of shortness of breath or chest pain, you should have some documented chest assessment and other parts of an appropriate exam. So be aware of those check boxes. Be aware when the vital signs or the physical assessment don't match the dispatched nature, the narrative, or the interventions and procedures you perform. So they all have to make sense together. And then be aware or a potential pitfall for when your documentation doesn't support a variance from the protocol. I think we all recognize that we can't predict every possible scenario out there. So the protocol is really set up as guidelines, and there are times you may need to do something a little different. Well, that needs to be explained as part of your documentation so that if you're called to task, you can explain it. And then avoid the editorial comments, and I think I've talked enough about that. Just a thing about vital signs, for those of you that remember when Dr. Stevens was our Associate Medical Director for Pediatrics, her number one complaint about run reports was lack of adequate vital signs. Vital signs are cheap and easy. Often the machine does it for us, but we need to get the vital signs. So, the original four, blood pressure, pulse, respiratory rate, and temperature. I think temperature is less important for the majority of the patients, although some patients may need to have their temperature obtained. In regards to blood pressure, if the blood pressure doesn't seem to make sense and you're using a mechanical device to measure the blood pressure, do it the manual way and verify that the blood pressure reading is correct. So there can be times when patients have a blood pressure that could be 60 over 40 on the machine, and you do a manual pressure and it's 95 over 60, or vice versa, where the machine is quite high and you do a manual and the blood pressure is normal. So, if the vital signs don't make sense, reassess them. I think we also need to consider the other 5 recommended vital signs. Pulse ox is important. We do that on everybody. GCS, we really should be doing on all patients who are complaining of injury. So any patients with a trauma complaint should have a GCS documented on the run report. Pain scale before and after treatment, I think, is important. Finger stick blood sugar in any patient who is diabetic or has altered level of consciousness or is acutely and severely ill, always consider doing a blood sugar. And then capnography is out there. I use that as a surrogate for serum lactate or other causes of acidosis. I also use it for patients in respiratory failure. So if you have a patient with trouble breathing, we should have capnography. If you have a patient who appears to be septic, we need capnography because it's part of our sepsis screen. If you have a diabetic with uncontrolled diabetes, we should have capnography because it's a screen for diabetic ketoacidosis. Generally, if capnography is less than 28 or 29 and the patient's blood sugar is over 500, that's considered diabetic ketoacidosis until proven otherwise. You can start the patient on an IV fluid bolus and make a difference in their care. Quickly, just a couple documentation pearls, and if you've got others, please pass them on. But it's not what you say, it's how you say it. So, be objective, use your senses, document patient's verbal response exactly as stated, and use quotation marks. Then it is an observation. You are documenting what the patient's saying, and it's not seen as an editorial comment. And measure what can be measured and document it. Also remember to document responses to treatment. document patient condition on arrival at the receiving facility. So it's not just what do they look like when you get to the patient's side, what do they look like when you deliver them to the hospital. Get input from others on the call. Do you know, ask your partner, do you see something I don't see? And so on. And then if vital signs are abnormal, repeat them one or more times, although as I mentioned, I think our standard should be vital signs at time of arrival at the patient's side, vital signs at time of arrival at the receiving facility, and if the patient is acutely ill, a couple other times in between. Think about words that to avoid describe the patient's behavior rather than label it. So we try to avoid belligerent or uncooperative or drunk or obnoxious. It's more appropriate to say the patient is standing outside a bar, his gait is unsteady, and he's not oriented to time. I think most of us would take that to mean the patient's drunk. So I think document your observations rather than your interpretation of the observations. The patient could be belligerent or uncooperative. Well, it could be that they're hypoglycemic and need some sugar. So avoid those words. And again, avoid the editorial or judgmental comments. And then think about what would ever happen if I put something in a run report and it was subpoenaed or I had to go to court, or somebody asked for their medical records and they saw my negative comments and they took it to the local paper. So if you don't want it to be seen in the paper or read out loud in court, you shouldn't be writing it into the patient's medical records. So that's the last of it. I appreciate your time and attention. If you have any questions, concerns, or additional pointers in terms of how to improve documentation, please post them on Workplace. Thank you.